Okay, so let us study hydrocephalus. So hydrocephalus is opened from Bailey's and Love's short practice of surgery. So the total CSF volume is normally about 150 ml, and the production of CSF, it occurs in the walls of the ventricles and the choroid plexus and is about 20 ml per hour. So let us note this down. So what is the total CSF volume? The total CSF volume normally is about 150 ml. And what is the rate of production? So production of CSF is around 20 ml per hour. So the total CSF volume is 150 ml and production of CSF is 20 ml per hour. And what is hydrocephalus? So hydrocephalus refers to an increase in CSF volume with ventricular enlargement, often presenting symptoms of raised ICP. So what is hydrocephalus? It is an increase in the CSF volume with ventricular enlargement, which often presents with symptoms of raised ICP. So what is hydrocephalus? What is hydrocephalus? What is hydrocephalus? Or basically its definition is that it is an increase in CSF volume. What is the normal CSF volume? So the normal CSF volume is around 150 ml. So if the CSF volume is more than 150 ml, it will mean that there is an increase in CSF volume, and hence that is hydrocephalus. And along with an increase in CSF volume, there is also a ventricular enlargement. And the next point is that there is often symptoms of raised ICP. Often symptoms of raised intracranial pressure. So it is not the rule, but it often presents itself with hydrocephalus. So what is hydrocephalus? It is an increase in CSF volume with ventricular enlargement, which often presents with symptoms of raised ICP. Next is physiology of CSF flow. So physiology of CSF flow. So to know about the physiology of CSF flow, we must know about the ventricles of the brain. So let us draw a diagram. So we have the lateral ventricles. Which through a narrow channel drain into the third ventricle, which drains into the fourth ventricle, which then drains into the central canal. So this is the basic structure of the ventricles. So now let us label it. So this is the cerebrum and the lateral ventricles. and what to draw the cerebellum. So this is the cerebellum. So the lateral ventricles, the cerebrum, the cerebellum. This is the medulla oblongata. And this is here is the pons. And this is the midbrain. So what we are interested in is the ventricular system. So these are the lateral ventricles, the lateral ventricle, the lateral ventricle. This is the third ventricle. And this here, the diamond shaped structure, is the fourth ventricle. And they all drain downwards into the fourth ventricle. So let us know the circulation of CSF. So the circulation of cerebrospinal fluid, circulation of cerebrospinal fluid, CSF. So it forms in the lateral ventricles. CSF forms in the lateral ventricles, and then it passes through the interventricular foramen. Passes through the interventricular foramen, then to the third ventricle. Passes through the aqueduct of midbrain. So forms in the lateral ventricles, then through the interventricular foramen it goes into the third ventricle, and where it passes from the aqueduct of midbrain to the fourth ventricle. So in the fourth ventricle, we have three apertures in roof, one median and two lateral. Three apertures in the roof, one median and two lateral. And another exit is central canal of spinal cord. So three apertures in roof, one median and two lateral in the fourth ventricle or the central canal of spinal cord. So the three apertures they open in number 1, subarachnoid space around spinal cord and cauda equina. Subarachnoid space around spinal cord and cauda equina. And into the veins of the spinal cord. Veins of spinal cord. Or it opens in the cerebellomedullary cistern and pontine cistern. Cerebellomedullary cistern and pontine cistern. That is subarachnoid spaces in the cranial cavity. So from cerebellomedullary cistern and pontine cistern passes into the tentorial notch. Then to the inferior surface of cerebrum. Inferior surface of cerebrum. Then to the superolateral surface of cerebrum. Superolateral surface of cerebrum. From there it passes to the arachnoid granulations. From where it is absorbed. Into the superior sagittal sinus. Superior sagittal sinus. So let us see what is written in the book. So CSF flows from the lateral ventricles through the foramen of Monro to the third ventricle. So lateral ventricles into the interventricular foramina through the foramen of Monro to the third ventricle. Then down the cerebral aqueduct to the fourth ventricle. From the cerebral aqueduct to the fourth ventricle, where it exits to the subarachnoid space via the midline foramen of Magendie and the lateral foramen of Lashka. So in the roof of the fourth ventricle, there are three openings, three apertures in the roof, one median and two lateral. So one median is called the foramen of Magendie and two lateral are called the foramen of Lashka. CSF is reabsorbed into the arachnoid villi along the superior sagittal sinus. Now let us revisit the flowchart. So CSF forms in the lateral ventricles and through the interventricular foramina it goes down the foramen of Monro to the third ventricle, then through the cerebral aqueduct in the midbrain to the fourth ventricle, third ventricle aqueduct of midbrain to the fourth ventricle, where there are three apertures in the roof, one median, foramen of Magendie, median Magendie, and two lateral, foramen of Lashka, lateral Lashka, and the central canal of spinal cord, and in the roof, three apertures. The three apertures, they open in subarachnoid space around the spinal cord and chorda echina, or the cerebellomedullary cistern and pontine cistern, that is subarachnoid spaces in the cranial cavity. So in the spinal cord and chorda echina subarachnoid space, the CSF passes through to the veins of the spinal cord, and in the brain, in the subarachnoid spaces in the cranial cavity, it passes to the tentorial notch, to the inferior surface of cerebrum, to the superolateral surface of the cerebrum, and then from the superolateral surface of cerebrum to the arachnoid granulation, where absorption takes place into the superior sagittal sinus. So this is the flow of CSF. Now so let us see the clinical features of raised intracranial pressure Clinical features of raised intracranial pressure. So symptoms of raised ICP include high pressure headache, which is worse on cupping or bending forward, and low pressure headache encountered after excessive cerebrospinal fluid drainage, are typically worse on standing. High pressure headaches may be accompanied by nausea and vomiting. So, high pressure headaches may be accompanied by nausea and vomiting. Blurred vision, double vision, cranial nerve compression can result in eye movement and pupil abnormalities. Fundoscopy can detect papillary edema. So if we do fundoscopy, we can detect papillary edema, but this takes time to develop, so may be absent in the acute phase. So papillary edema takes time to develop, so may be absent in the acute phase. So let us note down our findings. So in clinical features, we have number 1, high pressure headaches. And high pressure headache is worse on cupping or bending forward. Worse on cupping or bending forward. And associated symptoms in high pressure headache are nausea and vomiting, blurred vision and double vision, blurred vision and double vision, cranial nerve compression can result in eye movement and pupil abnormalities. So if there is a cranial nerve compression, can result in eye movement and pupil abnormalities. Eye movement and pupil abnormalities. On fundoscopy, we can see papillary edema. Fundoscopy, we find papillary edema. And this papillary edema may be absent in acute phase. So in infants, the fontanelle is tense and bulging. In infants, the fontanelle is tense and bulging with an increase in head circumference and bulging scalp veins. As pressure rises, conscious level is impaired. As pressure rises, the consciousness level is impaired. In children, this is in infants, and now in children, Perinaud syndrome results from dorsal midbrain compression with a loss of upgaze known as sunsetting. So this is a picture of sunsetting. Perinaud syndrome with sunsetting. So this raised ICP requires urgent evaluation and management. Delay risks progression to cerebral herniation, and it can obviously result in cerebral herniation, resulting in cardiovascular instability, neurological deficit, and death. Vision may also deteriorate rapidly and irreversibly. So for two group of people, in infants, With infants, we find that fontanelle is tense and bulging. Fontanelle is tense and bulging. Head circumference is increased. With bulging scalp veins. And with increase in pressure, consciousness level is impaired. With increase in pressure, consciousness is impaired. So now in children, we see Paranoid syndrome. So what happens in paranoid syndrome is dorsal midbrain compression, which results in loss of upgaze. Which is also called sunsetting. So vision may also deteriorate rapidly and irreversibly. Vision may deteriorate rapidly and irreversibly. And cerebral herniation may result in cardiovascular instability, neurological deficit, and death. If there is a cerebral herniation, this can result in cardiovascular system instability, neurological deficit, which would result in death. So these are the clinical features. Let us revise. So clinical features of raised intracranial pressure are high pressure headache, which is worse on cuffing or bending forward. Associated with nausea and vomiting, blurred vision and double vision. Cranial nerve compression will cause eye movement and pupil abnormalities. On fundoscopy, we will see papilledema, which may be absent in acute phase. In infants, fontanelle is tense and bulging. Head circumference is increased. Bulging of scalp veins is found. Increase in pressure results in impairment of consciousness. In children, we see paranoid syndrome, which is dorsal midbrain compression, which results in loss of upgaze, sunsetting, which is shown here in the picture. And vision may deteriorate rapidly and irreversibly, and cerebral herniation will result in serious instability and neurological deficit, which may result in death. So there is one last entity called a low pressure headache. We saw high pressure headache. There is also a low pressure headache. What is a low pressure headache? It is encountered after excessive CSF drainage, typically worse when standing. Found on excessive CSF drainage, and it is typically worse when standing. So this completes the clinical features of raised intracranial pressure. Etiology of hydrocephalus. So types of hydrocephalus are three. Number one is obstructive hydrocephalus. Obstructive hydrocephalus. So how is obstructive hydrocephalus caused? It is caused by lesions within the ventricle, lesions in the ventricular wall, and lesions distant from the ventricle but with mass effect. So lesions distant from ventricle but causing mass effect. And then we have communicating hydrocephalus. Communicating hydrocephalus. So obstructive hydrocephalus, then communicating hydrocephalus. Can be caused by post hemorrhagic CSF infection, raised CSF protein, So number one is obstructive hydrocephalus, which is caused by lesions within the ventricular wall distant from ventricle, but causing mass effect. And communicating hydrocephalus is caused by post-hemorrhagic CSF infection and raised CSF protein. Then there is a rare phenomenon of excessive CSF production. Third is excessive CSF production, which is rare. So it is caused by choroid plexus papilloma or carcinoma. Caused by choroid plexus papilloma, or carcinoma. So obstructive and communication hydrocephalus almost always reflects obstruction or failure of reabsorption. So the distinction is important since obstructive hydrocephalus especially can cause very sudden deterioration with coma and death. So obstructive hydrocephalus can cause sudden deterioration with coma and death. And because lumbar puncture in this context carries a risk of herniation. Of the brainstem and cerebellar tonsils due to resulting differential pressure changes, sometimes termed as coning. So what happens is, in obstructive hydrocephalus, there is a risk of sudden deterioration with coma and death. Sudden deterioration with coma and death, and if lumbar puncture is done, it can result in herniation of the brainstem and cerebellar tonsils. Lumbar puncture can result in herniation of brainstem and cerebellar tonsils. Which is termed as coning. So for communicating hydrocephalus, lumbar puncture is of diagnostic value. For communicating hydrocephalus, lumbar puncture is of diagnostic value. Deriving an opening pressure and assessment of CSF contents. So from lumbar puncture we can derive an opening pressure, and we can also see the CSF contents in the system. It is also therapeutic. So the range of typically between 10 and 30 ml of CSF with the goal of halving the opening pressure can relieve the hydrocephalus, at least temporarily. So we have seen obstructive hydrocephalus and the role of lumbar puncture in obstructive hydrocephalus. Now we'll see communicating hydrocephalus. So lumbar puncture in communicating hydrocephalus is both diagnostic and therapeutic. Diagnostic and therapeutic. So in the diagnostic part we can assess the opening pressure. Number 2, we can assess the CSF content. So in diagnostic part we have to see opening pressure and the CSF content, and the therapeutic goal can also be achieved if drainage is typically drain approximately 20 to 30 ml to half the opening pressure. Opening pressure. So this is therapeutic. Lumbar puncture. Treatment of hydrocephalus in the emergency settings usually involves CSF diversion. So treatment of hydrocephalus in the emergency settings usually involves CSF diversion. For example, using an external ventricular drain. Management is discussed further in the treatment of hydrocephalus. Disorders of the CSF flow with poorly understood mechanisms manifest in two syndromes: normal pressure hydrocephalus and idiopathic intracranial hypertension. So we have normal pressure hydrocephalus and idiopathic intracranial hypertension in disorders of CSF flow. So normal pressure hydrocephalus. Normal pressure hydrocephalus. So this is an important cause of dementia, since it is readily irreversible. Normal pressure hydrocephalus is an important cause of dementia, typically presents with a triad. What is the triad? Gait disturbance, incontinence, and cognitive decline. So normal pressure hydrocephalus is an important cause of dementia. Important cause of dementia. So symptoms are triad. Clinical features, we have a triad. What is it? So the triad is gait disturbance, gait disturbance, incontinence, and cognitive decline. The clinical features are triad of gait disturbance, incontinence, and cognitive decline. It may occur de novo or on a background of previous brain insults, including subarachnoid hemorrhage, head injury, meningitis, and tumor. So, normal pressure hydrocephalus can occur de novo or if there were any previous brain insults, including subarachnoid hemorrhage, head injury, meningitis, and tumor. Ventriculomegaly is evident on imaging, although this is also seen in the context of cortical atrophy due to the dementia pathologies. So, ventriculomegaly can also be seen in the context of cortical atrophy due to other dementia pathologies. So, an important point is ventriculomegaly. Ventriculomegaly. So, there is ventriculomegaly. Ventriculomegaly, which is evident on imaging. Ventriculomegaly can also be seen in other dementia pathologies. CSF pressure at lumbar puncture is typically normal, hence the name normal pressure hydrocephalus. So, CSF pressure is typically normal, but it is believed that intermittent elevations in pressure may be involved in the etiology. Intermittent elevations in pressure may be involved in the etiology. Lumbar infusion testing involves insertion of a fine drain at lumbar puncture, followed by measurement of the CSF pressure changes associated with a fluid challenge. So, lumbar infusion testing is done, involves insertion of a fine drain at lumbar puncture, followed by measurement of CSF pressure changes associated with a fluid challenge administered through this. So, what is done is lumbar infusion testing is done. Lumbar infusion testing. Insertion of a fine drain at LP, but it involves insertion of a fine drain at LP. Insertion of fine drain at lumbar puncture, and then measurement of CSF pressure. Measurement of CSF pressure changes. Measurement of CSF pressure changes associated with fluid challenge administered through this fine drain. So let us reframe it. So what happens is, in the lumbar infusion testing, what we do is we insert a fine drain at lumbar puncture, then we give a fluid challenge through this, and then we measure the CSF pressure changes associated with the fluid challenge. This will give us information about the likely benefit from the shunt insertion. So this is a pineal tumor which is causing obstructive hydrocephalus, and this is a gross hydrocephalus in a neonate with a very prominent temporal horns and fourth ventricles. The fourth ventricle. Next is idiopathic intracranial hypertension. Next up is idiopathic intracranial hypertension. Idiopathic intracranial hypertension. Idiopathic intracranial hypertension. So, idiopathic intracranial hypertension. Idiopathic intracranial hypertension. So this condition presents with features of raised ICP with and without an underlying tumor. Raised ICP without an underlying tumor. Explaining the old terms for the condition, pseudotumor cerebri. So previously it was called pseudotumor cerebri or benign intracranial hypertension. So previously it was famously known as pseudotumor cerebri or benign intracranial hypertension, and now currently it is known as idiopathic intracranial hypertension. So this description is misleading since idiopathic intracranial hypertension can progress rapidly to blindness. Can progress rapidly to blindness. The patient, typically a young overweight female. So how is the patient? Patient is typically a young overweight female. Describes a headache typical of raised pressure and visual deterioration. So let us note everything down now. So how does it present? Presents with raised intracranial pressure without an underlying tumor. Without underlying tumor. The old term for the condition are pseudotumor cerebri or benign intracranial hypertension. So what are the old terms for this condition? Pseudotumor cerebri or benign intracranial hypertension. And important point is that it can progress rapidly to blindness. Progress rapidly to blindness. So what are the symptoms? Or presentation, we can say. So symptoms or presentation are typically young overweight female, with headache, which is typical of raised pressure and visual deterioration. So there is headache and visual deterioration in a typically young overweight female, and when we do examination it may reveal papilledema and occasionally cranial nerve palsies. So in examination we have papilledema, and occasionally cranial nerve palsies. Occasionally cranial nerve palsies. So the imaging is unremarkable. Lumbar puncture demonstrates a raised opening pressure of more than 25 mm Hg. Raised opening pressure of more than 25 mm Hg. Number 3 is lumbar puncture. Opening pressure is raised. Of opening pressure more than 25 mm Hg. Opening pressure is of more than 25 mm Hg. The diagnosis is one of exclusion and the etiology is not well understood. So if we can exclude everything, we can make the diagnosis. Diagnosis of exclusion. So idiopathic, since it is idiopathic intracranial hypertension, the diagnosis for it to be idiopathic is that we have to exclude everything including tumor. Impaired CSF resorption may reflect raised venous pressure. Impaired CSF resorption may reflect raised venous pressure. Etiology is not well understood, either as a result of sinus thrombosis or secondary to raised intra-abdominal pressure in obese patients. So it may be secondary to raised intra-abdominal pressure in obese patients. Weight loss and cessation of certain medications including the OCP is often effective. So in idiopathic intracranial hypertension, weight loss and cessation of certain medications including the OCP is often effective. This is combined with medical therapy using acetazolamide to reduce CSF production. For patients with visual field loss or visual failure despite medication, lumboperitoneal or ventriculoperitoneal shunting is offered. Optic nerve sheath fenestration by an ophthalmologist may also be employed. So, management. So, idiopathic intracranial hypertension. How is it managed? So we opt for weight loss, number 1. Number 2, cessation of certain medications such as OCPs, oral contraceptive pills. Then number 3 is acetazolamide. Acetazolamide is given to reduce CSF production. So acetazolamide is given to reduce CSF production. We might as well know what acetazolamide is. So acetazolamide is a carbonic anhydrase inhibitor which is also used in treatment of glaucoma. So acetazolamide will be used to reduce CSF production, and for patients with visual field loss or visual failure, lumboperitoneal or ventriculoperitoneal shunt is offered. So in visual failure, or visual field loss, you can plan a VP shunt, ventriculoperitoneal shunt or lumboperitoneal shunt. Ventriculoperitoneal shunt or lumboperitoneal shunt. B is optic nerve sheath fenestration can be offered. Optic nerve sheath fenestration. So these two things can be offered for visual field loss. So hydrocephalus and disorders of CSF flow, obstructive or communicating hydrocephalus may occur as a result of neurosurgical pathology or its treatment. CT is the first line of investigation. For communicating hydrocephalus, lumbar puncture can confirm raised CSF pressure and relieve it temporarily. So what is the first line of investigation? CT is the first line of investigation in hydrocephalus. Let us note this down here. CT is first line of investigation. First line of investigation. And idiopathic intracranial hypertension results in symptomatic raised CSF pressure without ventricular enlargement, typically in young overweight women. CSF diversion may be necessary to prevent permanent visual loss. Normal pressure hydrocephalus is a potentially reversible cause of dementia, presenting with gait disturbance, incontinence, and cognitive decline. Now, treatment of hydrocephalus. Treatment of hydrocephalus. So, acute obstructive hydrocephalus is an emergency because of the risk of rapid progression to coma and death, sometimes with very sudden deterioration. So, acute obstructive hydrocephalus is an emergency. Why is it an emergency? Due to risk of rapid progression to coma and death. And it's called a hydrocephalic attack. So we have an emergency situation. Called a hydrocephalic attack. Hydrocephalic attack, which is acute obstructive hydrocephalus. Acute obstructive hydrocephalus. It has a risk of rapid progression to coma and death. It may be relieved by addressing the underlying pathology. For example, by excision of a tumor. Most often, however, temporary ventricular drainage is required. Either as an emergency in an obtunded or deteriorating patient, or as a precaution. And in emergency in obtunding deteriorating patient, as a precaution during definitive surgery, considering the possibility for post-operative swelling. So this acute obstructive hydrocephalic attack would require a temporary ventricular drainage. Followed by a definitive surgery. So let us talk about external ventricular drain. External ventricular drain. So EVDs or external ventricular drains are as effective temporary measure to relieve hydrocephalus. So they are temporary measures. Most commonly they are inserted to the right of midline. Insertion is there, anterior to the coronal suture, so that the catheter tip rests adjacent to the foramen of Monro in the lateral ventricle. And why is it placed to the right of midline, anterior to the coronal suture? So that the catheter tip rests adjacent to the foramen of Monro in the lateral ventricle. The catheter is then connected to a drain set such that CSF drains when the ventricular pressure exceeds the threshold. The catheter is then connected to a drain set such that CSF drains when ventricular pressure exceeds the threshold, typically set at 10 to 20 mm Hg. Intrathecal antibiotics may also be delivered through the External ventricular drain. Lumbar drains are an alternative means of temporary CSF diversion, often used to manage CSF leaks resulting from communicating hydrocephalus. Also be a lumbar drains. Then we come to ventriculoperitoneal shunts. First, let us write down about external ventricular drains. So this is a temporary measure. And where are they inserted most commonly? Inserted to the right of midline anterior to coronal suture. Inserted to the right of midline anterior to coronal suture. And why is that? So that the catheter tip rests adjacent to foramen of Monro in lateral ventricle. This is done so that the catheter tip is adjacent to foramen of Monro. Adjacent to foramen of Monro in the lateral ventricle. Now ventriculoperitoneal shunts. Ventriculoperitoneal shunts. So ventriculoperitoneal shunting comprises insertion of a ventricular catheter into the frontal or occipital horn of the lateral ventricle. So ventricular catheter is placed into the frontal or occipital horn of the lateral ventricle, while a distal catheter is tunneled subcutaneously to the abdomen. Ventriculoatrial and ventriculopleural shunting is also possible. So ventriculoatrial and ventriculopleural shunting is also possible. And lumbar peritoneal shunts may be used in a communicating hydrocephalus or intracranial idiopathic hypertension. Lumbar peritoneal shunts may also be used. A shunt valve with an opening pressure that may be high, medium or low is inserted at the junction of these catheters. So a shunt valve with an opening pressure that may be high, medium or low is inserted at the junction of these catheters. Shunt valve. Selection of the shunt valve is a balance and must be tailored to each patient. High pressure valves may fail to allow adequate CSF drainage, whereas low pressure valves can overdrain. So to maintain the drainage must be tailored. The valve must be tailored to each patient. An anti-siphon system may be incorporated to prevent excessive drainage in the standing position. Programmable valves also are available. Variable opening pressures adjusted magnetically using a device applied externally over the valve. The valve system will also typically incorporate a CSF reservoir, which allows for percutaneous sampling. So these are the examples of ventriculoperitoneal shunt valves. And there is also a CSF reservoir, which allows for percutaneous sampling. So in ventriculoperitoneal shunts, there is a ventricular catheter, in the lateral ventricle. And it is connected via a shunt valve with a CSF reservoir. So this is a shunt valve. Which can be, shunt valve can be high pressure, medium pressure, or low pressure. Medium or low pressure. And through this shunt valve it is connected to the peritoneal catheter. And this system exists subcutaneously. Now shunt complications. So shunt complications can be overdrainage, can result in low pressure headaches, which are typically worse on standing. Collapse of the ventricles can cause accumulation of fluid or blood in the subdural space. Resulting in subdural hygroma or subdural hematoma. So let us see the shunt complications. So shunt complications are: number 1, over drainage. Over drainage, what does it do? Over drainage can result in low pressure headaches. And it is typically worse on standing. Typically worse on standing. Number 2, it can cause collapse of the ventricles, which can result in accumulation of fluid or blood in the subdural space. Collapse of ventricles, which can result in accumulation of fluid or blood in the subdural space, resulting in subdural hygroma or subdural hematoma. So it can result in subdural hygroma or hematoma. Number 3 is the slit ventricle syndrome. Describes the situation in children treated with shunts whose ventricles and subarachnoid spaces are underdeveloped, resulting in poor brain compliance. Number 3 is the slit ventricle syndrome. Slit ventricle syndrome. It occurs in children treated with shunts. Children treated with shunts. So in these patients, normal fluctuations in the intracranial pressure are exaggerated so that cuffing and straining may cause symptoms of raised ICP. So any shunt blockage may not be evident on scan as the ventricles fail to enlarge. Slit ventricle syndrome. Shunts are vulnerable to disconnection, infection and blockage. Shunts are vulnerable to disconnection, infection and blockage, with the result that 15 to 20% require replacement within 3 years. Within 3 years. Number 4 is disconnection, infection Number 6 is blockage. We can actually divide it into two. Shunt complications is patient-related complications. Patient-related and B is shunt-related. Disconnection, infection, blockage, and 15 to 20% require replacement within 3 years. 15 to 20% require replacement within 3 years. 75% of infections present within 1 month. 75% of infections present within 1 month, reflecting introduction at the time of insertion. %75 within 1 month, reflecting introduction at the time of insertion. Risk factors include very young patients, open myelomeningocele, long operation time, and staff movement in and out of theatre. So these are the risk factors for infection. So let us note down the risk factors. What are the risk factors? Risk factors. Risk factors are: number 1, very young patients. Very young patients. Number 2, open myelomeningocele. Number 3, long operating time. And staff movement in and out of theatre. The shunt is removed and external CSF drainage. Open myelomeningocele, long operating time, and staff movement in and out of theatre. Shunt is removed and external CSF drainage. A serial lumbar puncture instituted to cover a course of antibiotic therapy. So what should we do in infections? These are the risk factors. Treatment is, management is. Number 1, remove shunt. Then external CSF drainage. Serial lumbar puncture. Lumbar puncture. Number 3 is antibiotics. Once CSF sampling confirms resolution of the infection and normal protein concentration, shunt can be inserted at a new site. Then resolution, insert a new shunt. Insert new shunt. So after resolution and normal protein concentration, shunt can be inserted at a new site. The majority of blockages are attributable to cellular and proteinaceous debris, especially due to infection, but choroid plexus adhesions, blood clot, or failure of the valve mechanism may also be responsible. So about blockage, cellular and proteinaceous debris. Blockage is due to cellular and proteinaceous debris. Choroid plexus adhesion, blood clot, or failure of valve mechanism may also be responsible. So other causes are choroid plexus adhesions, blood clot, failure of the valve mechanism. Endoscopic third ventriculostomy. Ventriculostomy. So this procedure is especially useful in obstructive hydrocephalus due to aqueduct stenosis. So useful in obstructive hydrocephalus due to aqueduct stenosis. In obstructive hydrocephalus due to aqueduct stenosis. A neuroendoscope is inserted into the frontal horn of the lateral ventricle and then into the third ventricle via the foramen of Monro. Into the frontal horn of the lateral ventricle, then into the third ventricle via the foramen of Monro. The floor of the ventricle is then opened between the mammillary bodies and the pituitary recess. Opened between the mammillary bodies and the pituitary recess. Pre-drainage between the third ventricle and the adjacent subarachnoid cisterns is then possible. Without the infection risk posed by implanted tubing. So there is no infection risk of implanted tubing. Reblockage of this route is common, however, in many patients will frequently require a shunt. Reblockage of this route is common, and many patients will subsequently require a shunt. Rare but serious complications include damage to the basilar artery. Complications: damage to the basilar artery or pharyngeal damage resulting in permanent memory impairment. So what is the goal is to establish a free drainage between third ventricle and adjacent subarachnoid cisterns. Establish a free drainage between third ventricle adjacent subarachnoid cisterns. Adjacent subarachnoid cisterns. Complications are reblockage, damage to basilar artery, pharyngeal damage resulting in permanent memory impairment.